Hello everyone, welcome to Rehabilitation Sciences YouTube channel. And now today we are here with another session with Dr. G. Balaji, and he'll be talking about mechanical diagnosis and therapy, lumbosacral dysfunctions. We have Dr. Sagun Agarwal with us, and he'll be formally moderating the session, and he'll be introducing Dr. G. Balaji. Yes, sir. So Dr. Sagun, over to you, sir, please.
Good afternoon, everybody. We welcome you in the Rehabilitation Science Group. Thank you, Dharam sir. Today, we are having the privilege to have Dr. G. Balaji. Dr. G. Balaji would be taking today's topic on the mechanical diagnosis and treatment of lumbosacral dysfunction. Sir is professor and principal at Nagpur College of Physiotherapy. Sir has completed his bachelor's in physiotherapy from KMCH College of Physiotherapy and master's in physiotherapy, Shri Ramchandra Medical College of Physiotherapy. Sir is having more than 15 years of the teaching experience after PG. Sir has received various prestigious awards like Best Academician Awards, Best Researcher Award, Excellence in Professional Growth, etc. A lot of awards are in the Sir's back are there. Sir is the author of the textbook that is the Spinal Manual Therapy, that is published by the JP publisher, and along with this, sir has the numerous publication in national and the international journal. We welcome you, Balaji sir, on our channel. Thank you for giving time. Thank you, sir.
Thank you, sir. I'm very pleasure to have a webinar about the mechanical diagnosis and therapy in lumbosacral dysfunction. As a physio, we should go for kind of the diagnosis called as a mechanical diagnosis. So we'll be doing the diagnosis of physically, and moreover the physical diagnosis like kind of the mechanical in nature. Even the treatment, the physiotherapist, we used to do that. It is in the mechanical kind of therapy, the treatment. So in the lumbosacral dysfunction, those particular spine concern, so it is very important to have a mechanical diagnosis. So where is a problem? What kind of the issues? Where is that? So like that we are supposed to go for that in the mechanical diagnosis. And the therapy also should go in this mechanical way, applying this different kind of pressure, the direction of the pressures, the movements, that is also very important that properly that things, the direction is be decided and the amplitude of the force that has been decided and given by this therapist in the proper way, and definitely that will have a very good success rate. So now we'll see about what is a mechanical pain. So what is a mechanical pain? So mechanical, it is there is not no pathological cause, and there is a mechanical disturbances to soft tissue, and there is articular surfaces, and so all the mechanical pain is nothing but like a depolarize the nociceptors, the free endings of the nociceptors. That's by the mechanical forces like compressions and distractions and heat, cold, whatever maybe. Say for example, very gentle things. When you move your bend your fingers backwards, so what you are getting this pain, it is nothing but a mechanical pain. So that stretch, the exercise stretch, what is happening here, so the mechanical pain. So once this strain is relieved, once the force has been released, automatically the pain goes. So this is what the mechanical pain. So it's definitely it is deformation will occur on the mechanical forces. So it is intermittent pain. Naturally, it is intermittent pain. And that relief is definitely is a mechanical therapy only, like correcting the mechanical deformations and the mechanical forces. See, this is the mechanical force which creates a pain, and once the force been abolished, okay, and automatically the pain goes. So this is what the first one is the mechanical pain nature. So what is the mechanical deformation? So now we should know about how the mechanical, there are kind of four usual the pressures, stress will be applied. So there is a normal stress applied to the normal tissue, so that will not produce the pain immediately. Okay, so we can categorize the two things. It's in the four. So normal stress applied to the normal tissue, and abnormal stress applied to the normal tissue, and normal stress applied to the abnormal tissue, and abnormal stress applied to the abnormal tissue. So these are the way this mechanical deformation can come. So normal stress, when there's a normal stress, so say for example, gently if you pinch, very gently if you pinch, you don't get any pain. So this is normal stress. The tissue also normal. So we gently pinch, no pain. But if you give abnormal stress, if you pinch very nicely, strongly, so definitely will get a pain. So the abnormal stress definitely to the normal tissue, that will cause a pain. And the normal tissue, normal stress which applied to the abnormal tissue. So tissue itself abnormal, and there is a normally any stress applied. Say for example, if there is a kind of severe inflammation or kind of the injury is there, even if you blow the air, that itself can cause a pain. So the normal stress applied to the abnormal tissue, definitely it can also cause. And of course, abnormal stress applied to the abnormal tissue, definitely which will cause enormous pain, the severe, very severe pain. So this is what the mechanical deformation. Now we'll see about what is a chemical pain in nature. So the chemical pain in nature is nothing but like a chemical cause. The chemical cause like inflammation and the infections, any inflammatory signs. So that also is present. And the chemical substances which stimulate the free nerve nociceptors, that also can cause a chemical pain. So this kind of chemical pain, it is not intermittent, it is a continuous pain. Say for example, patient will say, sir, once I lie down on the bed and throughout night continuously the pain, there is no gap. So this is a chemical pain, it's inflammation which causes the pain. So there's a continuous pain. And definitely this will relieve the chemical therapy like drugs, anti-inflammatory drugs and antibiotics. The patient have infections, antibiotics. So if it is inflammation, anti-inflammatory drugs, so that also will be required. And traumatic pain, we'll see what is a traumatic pain. So there is a pain during and followed by the injury. If there is an injury and so during that, at the time of injury, there is a it's called mechanical pain. So there is something is deforming. Okay, so there is a damaging soft tissue. There is a mechanical deformation occur at the time of injury. Say for example, if you have a blade, something just if you cut the blade on your skin with the blade, if you cut the skin, so what happened that the tissues are damaging at the time of injury. So there's a damage of the soft tissues. So there's a mechanical. Followed by that, next day, what happened? There is inflammation is starting around that injured area. So that is the inflammation. So the traumatic pain is have two things. One is a mechanical pain in nature. Then followed by there is an inflammation. So the mechanical therapy like positioning, strapping, immediately. That's what immediately after the injury, all the things will be applied to minimize the severity and that will protect the things. Severity of mechanical pain. So chemical therapy later, once the inflammation, all the things after that the wound is been get any infection. So definitely that kind of chemical therapy will be required, like antibiotic or anti-inflammatory therapy. So now we'll see about what is the importance of the lumbar lordosis on the spine, lumbar spine. So lumbar lordosis, you all know that commonly, even the pregnant women, they will have a big tummy. So lumbar lordosis will be more, because the weight will be more in the abdomen, uterus. So line of gravity goes, so to prevent that, so they will be lean backwards. So lumbar lordosis will be there. So relaxing is an important this one, hormones. So you all knows about that. That relax the spinal ligaments, symphysis pubis, and the sacroiliac joint. So that also will be increase in lumbar lordosis. And there's a relaxin that present between this adolescence and the middle age. So that is very important hormone. So that will be responsible for the relaxing the ligaments. Once the ligaments are relaxed and the flexibility more and lordosis, good. And before the adolescence and the middle age, the difference of the lordosis between this kind of the two sexes. So only that kind of difference will be there. So lumbar spine will be flat and with the age. So due to the flex lifestyle. Say for example, morning we'll get up, we'll go to the wash basin and we'll lean forward and we'll wash the face. Then afterward, we'll have a breakfast and leaning forward, and we'll drive the bike and the leaning forward position. We'll go to the school, college, or office, or all maybe. So he'll be operating like that. So leaning forward, then have lunch, leaning forward, then again driving the bike, leaning forward, coming back, and we'll sit and watch in the TV, again leaning forward. So we'll sleep night. So we'll go to the side lying, and moreover we'll bring both the legs and hands together like that. So which gives a kind of more the lurch. So the hump, so which will be great on the back. So the flex lifestyle, we'll have flex lifestyle. In between, sometime we'll get a bore, then we'll do like this kind of full extension back do. Again, we'll come back as like a spring. So this is what the lumbar spine is. It's the lordosis, the curvatures is abolished because of the lifestyle. So the lumbar lordosis. Yes, even there are some other things also will be increase the lumbar lordosis. Like load in front of, I mean, I already told you in this pregnant women, even high heel shoes, okay, so line of gravity forwards and erector spine activity will be more, and pelvic tilt, increase lumbar lordosis, hamstring tightness that also will increase, and prolonged static standing position that causes the trunk muscles is fatigue, followed by the reduce the lumbar lordosis. So these are all the things of lumbar lordosis concern. Now we'll see about the basic one is called articular neurology. So what is that articular neurology? So this is called receptors, the mechanoreceptors. So these are the receptors type 1, 2, and 3, and type 4. Okay, so receptors. So these receptors will be located. Okay, articular neurology. So the receptors, the type 1 receptors, it's a thin encapsulator. And it is a static and dynamic. The behavioral characteristic is a static and dynamic mechanoreceptors, and it's a low threshold and slowly adapting things. And type 2 mechanoreceptors, it's a dynamic mechanoreceptors, and it is a low threshold and rapidly adapting. So it's this located on the fibrous capsules of the joints and the synovial layers, articular fat pads. These all the things type 2 mechanoreceptors. Okay. Type 3 is a thinly encapsulator. This locates on the surface of the joint ligaments. Okay, and this is dynamic this is also dynamic mechanoreceptors, and this is a high threshold, and it's a slowly adapting. And type 4 receptors. So this is a tri-dimensional, and there's a free unmyelinated nerve fibers, nerve endings. Okay, so this located on the tri-dimensional plexus of unmyelinated nerve fibers. Okay, so this located in the fibrous capsules of the joints, articular fat pads, okay, articular blood vessels also, right, free nerve endings. This locates on the joints, ligaments, right. This is a nociceptive mechanoreceptors. This is called as nociceptive mechanoreceptors, and very high threshold, and there is this non-adapting. And free unmyelinated nerve endings is chemosensitive. Chemosensitive, so to abnormal tissue metabolites. Okay, it's a nociceptive receptors. So these are the articular neurology. So these are the receptors will be stimulated the mechanical therapy. So what are the central effects of articular mechanoreceptors? What are the central effects of mechanoreceptors? So there's a reflexogenic effects and perceptual effects, and there is a pain suppression. So these all the kind of effects will be expected on the mechanical therapy. So reflexogenic effects, so manipulation of the individual joint, any one joints on the muscles they are giving. So there is not only the manipulated of the things, even that will manipulate on the remote muscles also. Say for a patient will have a pain on the back. So when you give the mobilization therapy on the spine, and definitely the patient who get a pain on the distal area, the muscles, so that also will be relieved. And manipulation give rise to the reflex changes on the muscle tone. So reflexively, when you give the mobilization, the muscle tone will be different. After the mobilization, the reflexively the muscle tone will be changed. So there is a changes happen. And perceptual effects, type 1 mechanoreceptors, what we have seen the type 1 mechanoreceptors. So that contributes a perceptual experience of postural sensation and kinesthesia. Many of the patients will say, sir, I do not know how I'm standing. I'm standing wrongly. No, I do not know, sir, whether I'm standing right or wrong. So this reason is the type 1 mechanoreceptors. So we are supposed to activate the mechanoreceptors. So automatically postural sensations and kinesthesias. Okay, so that also improve. And destruction of the articular mechanoreceptors that manifests the impairment of the postural kinesthetic sensibility. So this mechanoreceptors type 1 mechanoreceptor destroy. Then followed by that, the patient will have postural kinesthetic sensibility as impact. And the pain suppressants, when the we are stimulating the mechanoreceptors, so automatically the mechanoreceptors stimulate by manipulation. That definitely provide the presynaptic inhibition of the nociceptive afferent activity in the basal spinal nuclear neurons. So followed by that, the pain will be immediately suppressed. So these are the effects of the mechanoreceptors. We'll say what are the low back pain definitions. There are so many definitions are there, and this is what definition is given by the Norkinson. This acute, subacute, or chronic low back pain, which is characterized by either slowly or suddenly occurring rather sharp pain with or without radiation over the patellar, or slowly down the legs and concomitant restriction of motion. When subsiding to the chronic type, the pain will be a little less severe and continue for more than 2 months. So it's what the low back pain, the definition given by Norkinson. What are the factors of low back pain? The factors. So there are certain factors will be predisposed and precipitating factors. So what are the predisposing factors? Poor sitting posture. Nowadays, it is very, very common that nobody will sit on this erect posture, even including physios also. Poor sitting posture definitely is flexed positions and leaning forward. Definitely that will give a strain or absorbed by the ligament structure. So when I lean forward, definitely all the ligaments will be stretched and that absorbs the load. So that is a predisposing factors. IDP, intradiscal pressures. So if I'm not sit in the proper way, when I lean forward, definitely my pressure will fall on the anterior aspect of the vertebral column. So intradiscal pressure will be increased. So that's stated by the Anderson. And loss of extension range. We never do that extension. Moreover, all the times in the flexed positions, because or all the activities on the forward. So we operate, we lean forward, that one. So we don't do that. Even ADL activity is also not there in this backward something to do. So until unless we do, we have supposed to do the exercise. So the loss of extension range that causing the adaptive shortening of scar tissue in the anterior portion of the vertebra, and the frequency of the flexion again more and more frequent flexion. That's what I told the story. You will get up early morning, face wash to till night, go to the bed. When bed also we'll go to the side lying and lean forward, bring the thighs closer to the chest and like this, and we sleep. So the frequency of the flexion is more. What are the precipitating factors like unexpected and unguarded movements? This also will happen. Suddenly they turn or suddenly they lean forward. So they'll get a catch. They'll feel a shock type of feel. The patient will say, so when I tried to lean forward, sir, I got something shock, sir, from here to till the leg, complete leg. I could not able to stand. I just collapsed and fell down. Unexpected and unguarded movements. Unexpected and unguarded movements. So that is important precipitating factors. And prolonged and repetitive heavy weight lifting. Okay, definitely that will increase the intradiscal pressure. And increase intradiscal pressure, definitely that will reduce nutrition supply to the disc. So disc will become hardening earlier. So what are the pain histories? So what are the other things of assessment things? So first one is pain history. We are supposed to see that pain history, that the name, age, the sex, address, occupation of the patient, and where the present pain being felt. Okay, there is a central and bilateral or unilateral in origin. Okay, how long the pain been present? Okay, so we can ask whether it's acute or it's in the chronic, right? So how did the pain commence? So we can ask the patient to just explain how did you commence. You can patient will explain very detailedly. Is the pain is a constant or intermittent? Okay, if the constant is a mechanical, it's not a mechanical. So intermittent is a mechanical. So constant is like a chemical pain. It's maybe inflammations. So you have to differentiate that. What makes the pain worse or better? What makes the pain worse or better? Okay, it's a aggravating factor and relieving factor. Simply says, have there been the previous any episodes of low back pain? Okay, and we have to particularly these important classification. We have to ask for that whether do you have pain on cough or sneeze? Okay, any sleep disturbances, pain on arising in the morning. So this also will indicate the patient have inflammatory pain. On steroids, okay, whether the patient has taken any steroids in past or present. Then reason any weight loss. So we can also suspect the patient may have any kind of tuberculosis infection, anything there or not. So many times patient will come very silently. The pain, the patient is like a pain. So they'll have a pain in the lumbar spine or thoracic region, maybe linked with this tuberculosis also. Right. Any major other surgery, any saddle anesthesia, any bladder and bowel control, anything has been lost. So these are all the general other kind of pain history can ask. Then what other main mechanical examination? Yes, here we are supposed to come for the main mechanical examination. So the lumbar spine should be tested in the lying and standing. So moreover, we'll be testing many of the times we'll be tested on this only in the lying posture or in the standing. So we don't do that on the standing. So the lying postures will test and accordingly we will be decide that. So lumbar spine movements should be tested in lying and in standing. And the movements are like a flexion, extension, side gliding of the lumbar spine. The movements should be repeated. Okay, so what are the movements testing? And that's supposed to be repeated. Right. The pain and movements relations are like movements can produce the pain. Okay, if that's what mechanical things. Okay, we do the movement and there is a relation between the movements and the pain. So there is a movement, the movement causing the pain. Sometimes during the movement the pain is not produced, so there is not a relation of the movement and the pain. Okay, so that's the deformation is by the movements. Right, the movements can increase or decrease the pain. Surely, then only the deformation, right? So these are the mechanical pain. If the pain is not changed by the movements, okay, during flexion, extension, side flexion, anything you do, patients say, no, sir, I don't get any pain, but I get pain only in the night, sir. So the movement is not at all disturbing the pain. So the movement and the pain is not, so it's not mechanical pain. It is definitely like chemical pain. So patients say, once I lie down night, finisher, throughout night is horrible. So definitely it's inflammatory pain. So that how do we first categorize that? So in kind of inflammatory pain, the mechanical therapy will not work for that. So we have to first of all put the boundaries of that. What are the boundaries? Will come and fall within that on this mechanical pain. So what are the test movements? Like flexion in standing. There are only the 5 test movements. The flexion in standing. Okay, so ask the patient to wide apart the foot and lean forward. And very important, by leaning, we have to hold the thigh. The hand supposed to be support on the thigh, and they have to slowly lean forward. When the patient lean forward, then the upper body weight will be suspended by the support on the thigh, and as he go down forward flexion, and he can slide down. The hand can be slide down the thigh, anterior thigh, knee, and legs like that. Then okay, so this is what the flexion in standing. So in this flexion in standing, during this time, whether the patient have any pain or not. Okay, and the movements can be repeated almost 10 to 15 times, and we can record the pain. Okay, when the pain is come. Sometimes the pain will come first beginning, first 2 times of flexion in standing, the patient will get pain. Afterward, the pain will reduce and will nil. Okay, so we have to repeat. Right, other mechanical examination like flexion in lying. Now flexion standing over, and next put the patient on the lying, and we have to check flexion in lying. So knees will be flexed and bring towards the chest, and patients should be clasped and hold the knees by the hands. So pain on the first movements, and after repetition that should be recorded. Okay, so this is what the flexion in lying. Next, the mechanical examination is extension in standing. The extension in standing, standing with the hands on the back. Okay, so you are supposed to support on the glutes, okay, on the hand, and support the upper body in the backwards. So you have to lean backwards. So this is what extension in standing. So pain on the first movement, then after 10 to 15 times will be repeat. So after that, whether it is been increase, whether the pain is increasing or it is the same or the pain is decreasing, we have to find it out. So what is the test movement that will be deciding the therapy, the mechanical treatment. Then extension in lying. So now we'll put the patient in the prone lying. Okay, we'll ask the patient to move up. So shoulder, the lying prone with the hands under the shoulders and raising the upper half of the body by straightening the arms. Okay, the pain on the first arm, it's like push-ups like that. So we'll ask the patient to press the hand and lift up the upper part of the body. So pain on the first movement and after repetition. Okay, so 10 times repetition. So that will be a recording. Right. Yeah. The fifth mechanical examination is it is a little different. It is called side gliding in standing. So please differentiate. This is not a side flexion. This is called side flexion. So side flexion is this. Side gliding is this. So this is called as a side gliding. So this is what the side gliding. So the only the spine will be moving like this way. This is called as a side gliding. So the vertebra, there's a vertebra and this vertebra can able to glide sideways. This is called as a side gliding. Okay, this we can able to check it on the standing. So whether the side gliding is increase or decrease the mechanical deformation. So this will show about the lateral shift. There's a presence of the lateral shift. Nothing but the lateral shift is sciatic scoliosis. So we heard the terminology like a scoliosis, sciatic scoliosis, right? So the patient who have this kind of sciatic scoliosis, it is very, it is not so common all the back pain patients, but some patients they'll have come with this side gliding. Okay, so sciatic scoliosis. So we have to test whether the side gliding on the left side and right side both have to test. Okay, so the examiner will press both hands on the waist. Okay, so this is the chest and the waist, and the chest should be moves parallelly like this, and waist should be, this is the waist and this is the chest. So this chest should be moves like this, parallel each other. Okay, the pelvis, this is the pelvis, this is the pelvis, and this is a chest, and this will be moving this way. Okay, so this is what the parallel movement. It's a side gliding in standing. Hope I made it a clear explanation on the mechanical examination. We'll see about the centralization and peripheralization. Right, centralization is a pathology is present in the vertebral column. Okay, where there is a pain, there is a problem. Simply says, where there is a pain, there is a problem. Okay, so that's a centralization. So the problem is in the center and pain also in the center. This is centralization. Simply says, one word says that. Pathology is present, the vertebral column. Pain also will be localized on the vertebral column. Right? Peripheralization. Pathology is on the vertebral column, but the pain reflecting, it is on the distal. It's nothing but like radiating pain. So all back pain or low back pain, lumbosacral problems, dysfunction, all it is not a radiating pain. Okay, so whether it's a centralized or peripheralized. So the pathology is on the spine, lumbar spine, and patient will get a radiating pain. And he says, in the radiating pain patient, they will never say, sir, I have back pain. They will never complain to the physiotherapist, sir, I have back pain, sir. They will say, yes, sir, I'm getting pain on this leg. Yes, really down on the legs. So this is what main complaint of the patient. So after manual therapy, certain 1 or 2 setting of manual therapy sessions, the patient complaint will change. Patient will complain, now, sir, earlier when I come first day, I'm getting the pain on this leg, sir. Now I have terrible pain on the back, sir. That first session when I come, so there was no back pain at all, absolutely no back pain at all. I had pain on this legs. Now I got a pain, sir. Pain is shifting from here to there, sir. So physios can be very happy. Yes, it's good, great success. When the peripheralization becomes centralization, it is an improvement. The peripheralization, the radiating, that now has been impinged. So there is a radiating pain. Now that has been relieved. Now there is a centralized, the exercise, whatever you did. So it has a very good effect on the spine and even the extensor muscles, everything got a workout, and followed by that the patient will get a centralized pain, and this peripheral pain is radiating pain relieved. It's a great success. So peripheralization to centralization when the pain shift. So it's a great success. But reversely, if there is a centralized, the patient comes with this back pain, okay, after a few sessions of this manual therapy, later on patient got a radiating pain, so definitely it is worsen the condition. So we should be very, very careful for that. Mechanical diagnosis, okay. What are the mechanical diagnoses? Like three mechanical diagnoses only, that things. One is postural syndrome, dysfunction syndrome, and there's like a derangement syndrome. So what is that postural syndrome? So posture is a problem. Okay, if I sit slouch, okay, then I'll get a back pain. So if I correct my posture, sit erect, sit, so immediately the pain goes. So this is what the postural syndrome, right? So the mechanical deformation occurs because of the poor posture. So poor posture is causing the mechanical deformation. So treatment, just correct the posture. It's very simple. Correct the posture. No other things will be required. Sometimes the patient would have been there on the poor posture for a long time. Correct the posture and give the awareness to the patient how he is wrong in that. Then second one is a dysfunction syndrome. Dysfunction syndrome, like now it's adaptive shortening. Continuously the poor posture is there, so there is adaptive shortening. Continuously by leaning forward, all the flexor muscles is become short and extensor muscle become lengthened. So this is what the dysfunction syndrome. The dysfunction syndrome here is a flexion dysfunction, extension dysfunction, and side gliding dysfunction. Okay, that's a subtype. We'll see that. Derangement syndromes, yes, now it is absolutely a derange. Okay, it is not a postural and dysfunction. It is the arrangements of the spine itself something wrong. So if the IV disc is not sit on the place, it is comes out from it is a derangement. If the vertebra slip from that alignment, it's either moved anteriorly, its anterolysis is moved backward, it retrolysis is whatever, maybe its alignment is gone. So it is derangement. So arrangement of the vertebral column is become change, something is wrong. So it is a derangement, right? The patient who's come with this hamstring tightness is not a derangement syndrome. Okay, the patient who come with this postural syndrome, like it's not a derangement. So structurally there is some kind of defect. IV disc is moved out from the place, right? Protrusion, prolapse, extrusion, sequestration. Those are 4 grades of IV disc. Okay, right. So all the things coming under this derangement syndromes. What is the mechanical therapy? Right. So mechanical therapy. So here the mechanical therapy is going to correct. First, understand whether it's a postural syndrome. If the patient have postural syndrome, when we go with this kind of mobilization or manual therapy, it is not required. Just only thing is we have to understand whether it's a posture is a problem, right? It's a posture problem. So correct the posture, right? And advise the patient and properly input the patient how to correct the posture, how to maintain this correct posture. Very, very important that the wrong the posture is being continuously is adapted in his brain and he's habitualized to this wrong posture. So that has to be correct. If it is a dysfunction syndrome, you are supposed to teach the patient the stretching exercise. What are the muscles are tight, right? So the tight muscle has to be stretched. The lengthened muscle has to be shortened, so it should be properly positioned, right? So if it is a derangement syndrome, so confirm that it's a yes derangement. Definitely, the vertebrae are moved here like that. So that time only we are supposed to go for proper kind of other treatments. So whether sometimes it require, sometimes the vertebra, with the scoliosis, the vertebra will be a little side gliding and with rotation. So you're supposed to correct the scoliosis or the problem. Okay, so that time we are supposed to give this mobilization. Sometimes it's rotation mobilization of one side, both the side have a transverse process. One side vertebra transverse if you give mobilize, so the vertebra will be rotate. So there is a rotation mobilization we can give. Sometimes it's a rotation manipulation. We have to give a certain thrust. We are supposed to give that. So these all the things will be required, and based on that we are supposed first we are categorize the patient whether it's a posture, dysfunction, or derangement. So this is what the assessment of postural syndrome assessment form. Okay, you can just see here. Definitely it is an intermittent. All name, age, sex, everything will be seeing that. Okay, so intermittent, and when it is watched, when the patient is being sitting. when the patient is sitting. Okay, so right. So and when the patient is standing. So when the movement time is not a pain, right? When it is better walking, okay, and lying, when the posture is being corrected, lying for time also definitely the things will be. So the time is a better, right? The postural syndromes assessment continues here. Lumbar lordosis, definitely that will be accentuated, right? Lateral shift will not be there, right? All the test movements you do, there is no pain produced. There is no pain produced. The movements and the pain, there is no leak. So this is not coming under that. So it is coming under the posture. Only the posture is a problem. So postural, the syndrome will be things. So conclusion is a posture the problem. So what is the principle of the treatment? Postural syndrome here is a posture correction, sitting and standing. When the pain has come, okay, sitting and standing. So that posture has to be correct. Sometime and all we are supposed to correct the posture in the office. So ergonomic advice that also will be required for the patients. So right. Okay, postural syndrome. Yes, we already seen that posture corrections, maintaining the long period. If the patient is not able to maintain, what to do? So you can advise the patient to take a small towel, a rolled towel, and keep it on the lumbar spine, just above the belt line. Just above the belt line, you can keep a rolled towel on the things and back rest. So the lumbar lordosis will be maintained even sitting with back rest also. All right. So this is what main important the treatments. Yes, if the pain comes in the lying posture, okay, lying posture and surface of the lying posture, okay, so that all thing has to be checked. Even rolled towels can be given on the supine lying portions on the lumbar spine. So lumbar lordosis can be maintained. Okay, so adaptive shortening. Sometimes if it is continuous, the postural things will be neglected. If the postural syndrome is neglected, and then you'll switch on to the next stage. So that is what the dysfunction syndrome. Okay, so adaptive shortening, if there is adaptive shortening is there, and shortening of the muscles, the soft tissues, if it is present, so definitely that impacts the function and the movements. So definitely sedentary occupation peoples that prone to develop the dysfunction because they adapted in particular the posture, wrong posture. Okay, so that causes the dysfunctions, right? So good posture and exercise very important. So what are the dysfunction syndrome assessment? So what are the dysfunction syndrome? This is also intermittent, but here you can see that even not only sitting, even bending movements also the patient will get a pain. Okay, lying prone, okay, commonly standing, walking, lying supine, the patient will get a pain, right? Dysfunction syndrome. Yes. So what are the movement? What are the test movements? There are 5 test movements. Okay, flexion, extension, side gliding. Okay, so deviations also. So whether there may be the flexion as a minimal movement loss will be there. Extension, there may be the major loss. Okay, already flexed position. So extension will be the difficult one, right? Even test movements, all other test movements like there may be that the pain will come at the end range because of the dysfunction, the muscles and the soft tissues become shortened, so that will not allow the complete range of motion, right? So what is the treatment for that is the principle of the treatment. Again here posture correction is a must. So before posture correction we are supposed to do the proper the stretch the soft tissues. If the flexors are the tight, so we are supposed to go for the extension principle and the flexors will get stretched. Then followed once it has been completely stretched and all the shortening has been relieved, then we can go for the posture correction and we can make the patient to maintain the right posture for all the time, right? So this is what the dysfunction syndrome treatment, the principle, right? Yeah, the postural instructions. Okay, yeah, advise the patient not to overstretch the tissues. Very important here. The physios should give the proper advice and warn the patients also. Sometimes when they teach the patient the self stretch, so they may do the overstretch. Next day, patient will come and say, "Yesterday I got a pain here. After stretch, my pain is in this." So it is overstretch. Sometimes the patient also would have done for overstretch. So warn the patients also and repeat the stretch gently and then check the movements, how the movements is improved. Okay. And again, the posture correction is very important after that one. So this is a flexion dysfunction syndrome, and this is extension dysfunction. Okay, extension dysfunction. Sometimes the patient will come with this exaggerated lumbar lordosis. Okay, exaggerate lumbar lordosis. So extensor muscles are more tight. Okay, the flexion will be difficult. So that also will happen. Okay, there are some patients, I have seen the patient who have exaggerate lumbar lordosis. We'll ask them to bend forward, even the standing, so they cannot be able to bend the lumbar spine completely. So it will be maintained the stiff like this, and it cannot be able to completely bend. So the problem is that the soft tissue of this extensors, so it's become adaptive shortening. So that also that is called as an extension dysfunction. Side flexion dysfunction. Yes. Okay. So what is the treatment of flexion dysfunction? So presence of loss of flexion. Okay. So the flexion will be reduced. Okay. So the dysfunction is commonly seen in the patient with lumbar lordosis. Okay. The patient usually unable to sit on this slouched positions. Okay. So that kind of position we are supposed to stretch the muscle. In order to achieve the full stretch, the flexion in standing can be the preferable. So make the patient to stand on the standing position. So we'll have them to bend forward, so we can get a full complete range of the movements, and followed by the complete range of movements, the flexibility will be improved. Right. So what is a treatment for the side gliding dysfunction? So in dysfunction, the patient who's come with this kind of side gliding, so there's a deviation. So when in the dysfunction, there is a deviation in flexion that occurs on the lateral shift sides. So that determines whether the lateral shift is been relevant to the present condition. So that also has to be checked. So this kind of patient who's come with this lateral gliding, okay, so they'll have a lateral gliding dysfunction. So we have to check whether the patient have once the spine has been shifted like this is called as a lateral gliding, okay, side gliding, okay, lateral shift or side gliding. So this kind of side gliding, the patient will have one side is short, another side is in length. So that has to be correct. Okay, first you have to correct yourself. Okay, the therapist can correct. For example, if this is the what like that, and therapist can push the ribs on one side and the ASIS pelvis in the opposite direction. It's like that. So can push it back and push the pelvis also in the opposite direction. Then after that, we can teach the patient for self-correction of lateral shift. So self-correction of the lateral shift is very important. We can ask the patient to hold the finger on the rib cage, okay, another thing hand on the pelvis, okay, so both will be moved this way. So patient is supposed to force the chest on the opposite direction and pelvis in the opposite direction. This way, when he give the opposite both together, I mean parallelly, simultaneously, so the correction also can happen. So this is what the side gliding dysfunction. Moreover, this will be required like a practical demonstration will be the very fine. Now we'll come to the point of what is a derangement syndrome. Okay, so what is a derangement syndrome? This. See, here pain is a constant, but we have to differentiate whether the movements, whatever the test movements, that time the pain is increased or decreased. We are supposed to check it. Yes. So bending, sitting, rising from standing, lying supine. So these all the things will be worsened. When it is better, okay, when the patient is walking or lying prone is quite better, right? Okay. So the derangement syndrome, the test movements are, okay. So these are the test movements. Yeah, the flexion in standing that produces the back pain, and repeated flexion in standing, so the thigh pain will become worsened. And extension in standing that increase the pain, and repeatedly if you do, so that will be abolish the back pain. So extension in standing. So the when you repeat the movement, just we have to what are the test movement? The movement you do, pain comes. Repeatedly the movement do, the movement followed by repetition of the movement, the pain is worsened. Then you are supposed to avoid the movements. One particular extension movement you do, pain comes. Repeatedly extension movements you do, pain reducing. Yeah, that is a selection of the movements. So that is the principle you have to take that, and that movement is ask the patient to repeat again and again. So when the movement is again and again repeat, so automatically the pain will be gradually reducing. Right. So if there is a derangement syndromes. Okay, so what is the principle of the treatment here is a lateral shift correction. Okay, definitely the derangement syndrome will have a scoliosis, lateral shift, sometimes increase lumbar lordosis. Even that also is a lateral shift corrections in extension in lying, right? So what are the other general common test things? SLR and FABER, flexion, abduction, and external rotation, and reverse FABER. Okay, test also you are supposed to do that to find it out whether there is a kind of any sciatic scoliosis. We commonly do the SLR and whether the patient have any pain or not. And very important here in the SLR, whether while lifting this leg SLR, whether the pain, whatever the pain, the patient's original pain is reproducing or not. The moment it reproduces the patient's original pain. Sometime when you do SLR, patient will get a hamstring tightness. So when you do the SLR, definitely patient will get a pain. Patient says, I'm getting pain here. But that pain is a hamstring tightness. So which hamstring gets stretched. But that mistakenly, we may take that, okay, it's a radiating. Okay, so whether it's a confirmed, sir, now are you getting the pain? This pain is your original pain. What is your complaint pain is this? Patient said, no, sir, that is different, sir. It has come from here to there and like a shock type of pain. This is like a pulling type of pain. Yeah, no, this is different. So what else this? This is a hamstring tightness. So hamstring is stretched. So because of that, stretch pain is there. So straight leg rising. So the test is very simple. How you interpret, how we interpret. So accordingly, the variations. Right. So in case of any side gliding, okay. So while doing the deviation in the flexion, so that is a compensatory movement for the nerve root impingement. In case any nerve root is impinged, okay, particularly this nerve root is impinged. When you do the SLR, the patient will do this kind of the shift. Okay, so he will do the deviation. So you will do little deviation. Why? Because the nerve is compressed, and when you do the SLR, the full course of the nerve will get stretched completely. So already as it is impinged here, so that is overstretched and earlier it will stretch. So even if after 70 degrees, the nerve supposed to get stretched, but here it's a 30 degree, 40 degree, so the nerve gets stretched because already it's got impinged, and the length of the course of the nose, it's already is sacrificed, right? So the patient will do the deviation in flexion. So even other movement, test movement like commonly in back pain patient, the FABER, so flexion, abduction, external rotation. So that will test the anterior sacroiliac joint ligaments, and we'll do the flexion of the hip, okay, abduction with external rotation. So the groin region will get stretched. So there's that definitely that will give the stress to the anterior sacroiliac joint ligaments. Reverse FABER test, cross the leg flexion, then we have to go for adduction, and there is an internal rotation. Actually, it's a reverse FABER. Okay, so with adduction with internal rotation, so the posterior sacroiliac joint, the ligaments that will get stretched. Okay, so the patient get a pain exactly on the gluteal region, on the sacroiliac region, while doing the reverse FABER test. So can say that maybe there's a sacroiliac joint, posterior sacroiliac joint is the pathology. The problem is there like that. So what are the stages of the derangement? So what are the stages of the derangement? We have seen the derangement, yes, postural syndrome, dysfunctional syndrome, we have seen, derangement we have seen. So we'll see a little detail about what is the derangement, what are the derangements. So there are 7 derangement syndromes out there. Derangement 1, derangement 2, 3, 4, 5, 6, 7, right? We'll see what is the first derangement 1. So the derangement 1 is a central or symmetrical pain across L4, L5 and rarely back or thigh pain. And there is no deformity, no scoliosis, kyphosis, nothing. So no deformity. So it is a derangement 1. It's very simple back pain. Okay. So central or symmetrical back pain. Okay. Patient have central or symmetrical pain. Right. Okay. No ipsilateral side or thing. Only central, only the pain. Derangement 2, central or symmetrical pain, same as like derangement 1. Right. With or without buttock or thigh pain. Okay, so now the pain is been little extending to the buttock region or sometime on the thigh region, and with the deformity of lumbar kyphosis. So see the difference between this derangement 1 and 2. So this is what that. So the deformity of lumbar kyphosis. Patient have lumbar kyphosis. Have you seen that lumbar kyphosis? Lumbar lordosis is there. So lumbar spine has lordotic curvature. The lordotic curvature become flat and it become kyphotic, so almost like bend, right? So this kind of lumbar spine, it's like a rod. Okay, lumbar spine is very rigid, and it's even we can very classically we can able to palpate, and we can see that spinous process of the lumbar spine very nicely. We can palpate, and we can see on this things on spinous process very visible. Right. Derangement 3. So this is unilateral. This is not a central or symmetrical one. This is something different. So this is unilateral or asymmetrically. Only one side, either left side or right side. Okay, with or without buttock or thigh pain and no deformity. Almost derangement 1 and 3 will be almost similar, but the only thing is derangement 1 is a center. This is unilateral, either one side. Okay, so either left side or right side. And here also no deformity, derangement 1 also no deformity. Now, derangement 4, unilateral or asymmetrical. Okay, so same thing as like derangement 3. Pain across L4, L5, with or without buttock or thigh pain, and with deformity of lumbar scoliosis. Okay, so derangement 2 is a central one, and here derangement 4 is a unilateral. Right, and there is a kyphosis, here is a scoliosis. So this is what the difference between 2 and 4. So derangement 1, very simple, no deformity. Derangement 2 is lumbar kyphosis and central pain. Derangement 3 is a unilateral pain and with the buttock thigh pain, thigh region radiation, and no deformity. 4 is a unilateral pain and lumbar scoliosis, and with or without buttock or thigh region. Till the thigh, the pain is there. So this is derangement 4. Right. Now we'll see derangement 5, 6, 7. Right. So derangement 5. This is unilateral or asymmetrical pain, of course. One side. Okay, it is not a center. So with or without buttock thigh pain, sometime the pain may extending below the knee also. So here's the first one. Now it is become little more severe. So till derangement 4, it is on the thigh region only the pain is extending. So now it is crossing the knee and come to the leg. So derangement 5. This is derangement 5, and there is no deformity at all. Patient will say simply that pain is there till the cough, and there is no deformity, no scoliosis, kyphosis, lumbar lordosis, nothing. So it is this kind of things coming at derangement 5. Derangement 6. Unilateral, or this is also unilateral one, with or without buttock. Okay, so with leg pain, extending below the knee also will be extending the radiating pain, and now with the scoliosis of sciatic scoliosis. Okay, now the deformity is like a sciatic scoliosis. Okay, so derangement 5 there is no deformity. Now derangement 6 there is sciatic scoliosis. All the features with the scoliosis, sciatic scoliosis seen. This is derangement 6. Derangement 7. Right, symmetrical or asymmetrical pain with or without buttock thigh pain. Okay, but here very rarely only that till the pain will be extending on the leg. But the deformity is like exaggerated lumbar lordosis. Okay, exaggerated lumbar, increased lumbar lordosis. So the lumbar lordosis increased and the pain, radiating pain continues on the buttock and the thigh regions. So this is coming under derangement 7. So these are the categories of derangement syndromes. So total 7 derangement syndromes. So just to refresh it, derangement 1, 2 no deformity 1, 2 is a kyphosis, 3 no deformity, and 4 is lumbar scoliosis. Right, and derangement 5 again no deformity. Derangement 6 sciatic scoliosis. Derangement 7 is lumbar lordosis. So these are the deformities. Okay, will be seen in this derangement syndromes. Right. Okay. So what are the derangement syndrome? The treatment. So here the derangement syndrome is very important. The principle of the treatment is here is a peripheralization. So we are supposed to bring the peripheralization to the centralization, and deformities are very important. Okay, the patient have kind of side gliding. The patient who have the side gliding deformities, so those people will have a scoliosis deformities also. So scoliosis patient, the vertebra will be not only will be tilt sideways and tilt, and it also will be rotate. So the tilt and rotate. So very important when you go for the mobilization. When you go for the mobilization, okay, say for example, this is the vertebra. If this is the transverse process, right? So this will be goes like this and rotate. So what you're supposed to do that is, so there's a posterior 11 approach. So we can also derotate the vertebra, then we can go for the, okay, so then only thus the rotation component is very important. Okay, there's a two thing, rotation component and the side flexion also, right? So the reduction of the derangements, the principle of the treatment and maintenance of the reduction is very important. Okay, and recovery of the function. Once the function is recovered, then prevention of the recurrence. So you're supposed to teach the patient to maintain the posture. That's what last one. So these are the principle of the derangement syndrome treatment. So now there are kind of techniques. Okay, so what are the other techniques? There are only 17 techniques. Actually, this required a practical, complete the practical. So I'll be telling about the theoretical, what are the things. So, you know, first one is a lying prone. Any back pain patient comes, what I tell you, sir, you better you lie on the prone. Prone. So prone position when it comes, whatever the curvatures of the lumbar spine, it automatically will come. Very simple that. So prone lying. Second, another technique is lying prone in extension. So after that, 1 day, 2 days, then we'll ask him to lift the head and shoulder with the elbow support. Then extension in lying. Now with the hand support, like a push-ups, no? Like with the push-ups, head, shoulder, chest only up with the hand supports. And very important, the pelvis and lumbar spine not supposed to lift. But the patient who have the kind of stiff lumbar spine and automatically pelvis also will become up. So that kind of patient we can fix with a belt. We can take a belt, okay, something. We can tie the patient's waist along with a treatment couch. So that will be stabilize the lumbar, I mean the pelvis on the couch. So the patient will try to push and get up, and definitely there is an angulation. There is an angulation will be created like this. So there is an angulation. This is a head, shoulder, chest will be up. This is the pelvis. Okay. So automatically this angulation will be created over here, and that angulation will give extension moment on the vertebra. So vertebra will be moved backward. So if say for example this is till L5 you stabilize and L4 till L4 is moving, so the L4 is goes up. So there is a angulation will be extension. Angulation will be developed on the lumbar spine. Right. Next one, sustained extension. Okay, this one extension. Afterward, you're supposed to maintain the extension sustainedly. So what you're supposed to do that, there is a gradual extended couch are there. Okay, the upper end of the couch, there's a dividing will be there in the couch. Upper end, the head and part, we can also tilt. Okay, so lower part of the couch will be stable and upper part we can tilt. So that kind of things is we can ask the patient to lie on that. We can tilt the upper end. So the head, shoulder, chest will be without patient effort. We can also lift. So the patient till the chest level will be goes up and the pelvis will be there on the bed. Okay, so the bed will be like this. Okay, angulation. Right. Then extension in standing. Okay, this we already seen that there's a test movement also is said. Okay, keeping the hand on the buttock, very important. Okay, supposed to keep on the buttock, hand supposed to on the buttock, and push the pelvis and the move backward. Okay, upper hand will be moved backward. So this is extension in standing. Extension mobilization. Yes, now extension mobilization. Now further if the patient do that extension, the movement mobilization is not taking place. Now we have what can do. You can mobilize the vertebra during the extension, or that time you can keep your hand on the spinous process or both the transverse process. You can give anterior glides. So when anterior glides is nothing but it's a goes forward, the vertebra goes forward, and it is an extension is happening. Right. So extension manipulations. So certain when you mobilize certain areas, you can feel there is a resistance. So when there is a resistance, you can give a thrust. So there is a manipulation. Certain thrust we can give on this extension. That's a manipulation. So followed by the sudden thrust, yes, the resistance free. Then afterward, movement become easier. Okay, very careful, very careful that where the resistance you are feeling, and there you are supposed to use a kind of thrust force, and which will break the resistance, not break the tissues. Very important. Okay, very cautious. You have to do that. And rotation mobilization in extension. Now there is a rotation. So the vertebra, this is the vertebra. Last time I told you, this vertebra already is the rotator. Okay, there is a scoliosis there occur. So there's a side, okay, a side flexion and the rotation is there. So what is supposed to be how to derotate the vertebra? So if this is the vertebra. Okay, it is there from your side. I'm saying that. So this is the rotation is there. So this is what. So what you're supposed to do? You have keep the hand here on the strand. This is a transfer process. Transfer process. This side. Which transfer process is there? This one you keep your hand and apply the pressure. So when you give the pressure, automatically the transfer process will both will come to the level. So it will be derotations. So this is what the rotation mobilization you can give. Same way, when you do the rotation mobilization, you will feel somewhere is a thrust. Okay, the resistance. Resistance, you will feel the resistance torque. So you can give the sudden thrust. Sudden thrust is the give, then followed by the movements. Yes, free movements. So this is what the rotation manipulation in extension. The another 7 techniques, just briefly I will tell. Then sustained rotation, mobilization in flexion. Yes. Now this is the flexion principal component. So we'll make the patient to bring both the thighs towards the chest like that. Then you can rotate. Okay. So therapist can stand in one direction. So hold the leg, both the leg, thighs holding and pulling one direction. Upper part should be stabilized. Upper part of the body should be stabilized, and the pelvis, thigh, leg should be hold. Okay, in the forward position. Therapist should hold and pull it one direction. So this is rotation, mobilization. So rotation manipulation, same way. When you do the rotation, so you'll feel the resistance. So you can give sudden thrust. Right. And flexion in lying, we already seen that flexion in lying. And flexion in standing, yes, this also we have seen. And flexion in step standing, yeah, this is for step standing. So in the step, we'll ask the patient to keep the leg above and lean forward. So this is what the flexion in step standing. Right. The correction of the lateral shift, this already I told you in the correction of the lateral shift. So this is what the corrections. Okay, so if the patient has this, okay, so this is what their lateral shift. So correction. So therapist can keep the hand, one hand on the ribs, another hand on this pelvis. So we can give this parallelly. You can force. Self correction. We can ask the patient to keep the hand, one hand on the chest. Okay, ribs. Okay, sides of the ribs. Another hand on the ASIS. Okay, in standing position, not in sitting. So in the standing position, then you can give force equal, parallel each other. So this will give the self correction of lateral shift. Okay, so here are the things. I come to the conclusion. Thank you. Any queries? Be welcome.
Thank you, Dr. Balaji.
Yes, sir.
Thank you. It's a very nice presentation. In a short span of time, you have covered all the treatment and the assessment part. Dr. Harpreet, sir?
Yeah, good evening, sir.
Good evening, sir.
Sir, it was a very fine presentation, I think, detailing each and every aspect of low back pain and how patients should self-manage, when to manipulate, when to mobilize, how to assess different types and classifications of low back pain. Sir, what we have seen in our practice is that a lot of patients go towards chronic low back pain. Despite coming for therapy, they still develop chronicity of their condition. So is there any reason or how to manage that chronic low back pain?
Sir, mostly the chronic low back pain will come the patient who is neglected already. They have neglected the case, the chronic low back pain, and moreover, the flexibility component, the movements is very stiff. It is like I'll tell my patient your lumbar spine like a rod. It just looks like a rod. Mm-hmm. So when we try to mobilize the spine, absolutely it is all the spine gives very great resistance. So we don't get the kind of free movements. And it's very important, the chronic back pain, low back pain patient, when you give this force, very careful, we can increase the force gradually. Sometimes chronic back pain patient, low back pain, will give more resistance, more force on the first beginningly, which can give next day the patient will get severe pain. So we'll be a little careful, chronic low back pain patients, because definitely the flexibility component is almost zero, very less, very less. So we'll be very careful mobilization, the force. Gradually, we can increase the threshold force.
So physiotherapists have long been involved in manipulation, mobilization, as well as exercises. But in recent times, we have seen that new therapies have been growing, like cupping, like dry needling, like trigger point therapy. And also there is the concept of kinetic chain. Do you believe in these concepts, and how important are they in the management?
Yeah, it's a good, valid question. Say I'll same thing. How I am answering to my patient, same way I'll also answer this question. There is a goal post, and there is a football is given to the player. The main aim of the player is kick the football and bring towards the goal and kick it.
Right.
So he might find us so many different techniques, different approach. He'll pass the ball to another person, so many tactics he'll do, and finally, main intention of that player is kick the ball into the goal post.
Right.
So there are many various, all the techniques,
Right.
the techniques, absolutely good. This is
we get your point. We get your point. A very diplomatic answer, but right. So thank you so much, sir, for sparing your time and your knowledge. And I'm sure that a lot will benefit from this lecture, sir. Thank you so much for being with us.
Thank you, sir. Thank you. Thank you for the opportunity given to me.
Thank you.
Thank you, sir.
Thank you, sir. Thank you so much.
Thank you, sir. Thank you, sir. Thank you. Thank you very much.